In order to explain the vaccination program, one has to understand herd immunity. So, what is herd immunity? When a certain amount of the population gets vaccinated to act as a shield against the COVID-19 virus, then it cannot establish a foothold to cause an epidemic or a pandemic. Around at least 65 to 75% of the population needs to be vaccinated to achieve full herd immunity. Best estimate to achieve herd immunity is about 2 to 4 years. Next. Next slide. Yeah. Vaccination historically has done well for the human population. For example, polio has been eliminated and many diseases like measles, tetanus, diphtheria, and flu has been controlled. Now, even cancers caused by the herpes virus can be prevented. I predict that this COVID-19 virus can be controlled and brought under herd immunity. For Christians, I urge you, brothers and sisters in Christ, to join together as one body to fight the pandemic. The Pfizer-BioNTech Moderna mRNA vaccine, the Oxford AstraZeneca AAV vaccine, as well as the Sinopharm vaccine, so far has reported efficacy of better than 50% required by the CDC for the FDA emergency use approval or full approval. Almost all governments have plans to vaccinate their populations. Understandably, the long-term side effects of the vaccine is not well known, but phase 3 studies have not revealed significant harmful side effects. In the days of old, in the 60s, we mostly follow what the health authorities and government proposed in vaccinations. We have diverse groups. Self-preservation takes place nowadays. Next. This is how we know what love is. Jesus Christ laid down his life for us, and we ought to lay down our lives for our brothers. This is the verse in 1 John chapter 3:16. There are a lot of fake news, articles with an agenda to sway readers on COVID-19. Some to provide fear. From the above, we are led astray. Next. 1 John chapter 3 verse 16. This is how we know what love is. Jesus Christ laid down his life for us, and we ought to lay down our lives for our brothers and sisters. This is the supreme example of love. God desires believers to know the word and to live it out. Christians are commanded to act in selfless sacrifice. Wait a minute. John 10. Yeah. Wait a minute. Yeah. Okay. John 10, verse 14 to 15. I am the good shepherd. I know my sheep, and my sheep knows me. Just as the Father knows me and I know the Father, and I lay down my life for the sheep. If Jesus can lay down his life for us, can we not get vaccinated for fear of side effects? Also, I urge my brothers and sisters in Christ to submit to the government policy for vaccinating the population. Next, slide number 5. Romans 13:1. Let everyone be subject to the governing authorities, for there is no authority except that which God has established. The authorities that exist has been established by God. Apostle Paul told Christians who are saved by God's grace should interact with the present government. We are told to set ourselves aside and to trust God to provide what we need through those in authority. Peter also teaches the same in 1 Peter 2, verse 13 to 17. Next. Of course, we do so if it doesn't go against the word, prevents us from disciplining and preaching. The act is not sinful. Therefore, I urge you, brothers and sisters in Christ, to join in to achieve herd immunity. Therefore, as a church, if we all get vaccinated, we can expect to be back as a full congregation to fellowship and glorify Him. Obviously, in a program like this, some may succumb to the rare side effects of the vaccine, as is known from many vaccine programs. But God has heavenly rewarded those who suffered for the good of others. Before I end, I would also like to stress on 2 points which make people of Malaysia proud. Slide number 6. You can see this is the slide of Dr. Wu Lian Tay. He was born in 1879 and passed on in 1960. Dr. Wu was responsible for inventing the modern-day mask and quarantine procedures, distancing, etc., what we now know as the SOP, in controlling pandemics in his days, bubonic plague and cholera. He was also elected for a Nobel Prize in Physiology, and he's from Penang. Point number 2, these modern-day vaccines would not have been made so rapidly available had China not released the full genome of the SARS-CoV-2 virus genome. All these vaccines need that for the spike protein to make the vaccine work. Amen. Yeah, that's it.
Good evening. Tonight I would like to talk to you about the COVID-19 vaccine and the virus, the known and the unknowns, and how we can reduce the incidence of infection and its severity. We have placed a lot of hope on the vaccine to be effective to turn our lives back to normal and our economy on its growth path. There are a lot of unknowns that we do not know regarding the vaccine, and I suspect that it will be in the second quarter of 2022 before we realize the benefits for the economy. The logistics of vaccinating 60 to 80% of the population will take us at least 6 months, let alone the availability of the vaccine, especially if 2 doses are required. At this point in time, China is able to produce 750 million doses a year. All the Western pharmacies have already been booked by developed nations. Also, The logistics of cold chain and manpower to do that for the developing country is a big ask. China will probably be able to double its capacity in 6 months to a year. What is known about vaccine? We know that it is 90 to 95% effective. Although early trials showed that there was no mortality, we now have a recent male nurse who had vaccinated 6 days earlier and contracted COVID. On the 7th day, was confirmed and later died. To be fair, he was looking after COVID-19 patients. But for an ordinary person, it is very likely that you would have had a chance for your body to make antibodies before being infected. There's also a decrease in severity and none required ICU treatment. Allergies were also detected in those with atopic tendencies like asthma and peanut allergies or drug allergies. These people should have their vaccines in the hospital where all the facilities are available should he need to be resuscitated. Ivermectin and hydroxychloroquine are used in developing countries with good results. What is not known? The fast track in developing the vaccine means there's still not enough data to show us the long-term, the medium-term side effects. The unknowns, like what response will be for those over 60 years of age and those with comorbidities. How long will the antibodies last? Do we need another one on the yearly basis like the flu? All these challenges will be gradually revealed just as the virus and its effects. On the virus, what is known? It is a coronavirus with a spike protein. Transmission is via droplets through direct or close contact during speech, coughing or singing. Its effects are infection causing inflammation and leaking of blood through the capillaries in our body and clotting in the blood vessels. There are 2 phases we know of in the disease. In phase 1, it starts with the exposure to the invasion of cells via the ACE receptors in our mucosal surfaces of the nose and mouth, and the ACE receptors are especially plentiful in the lungs and the kidney. They enter the cell and hijacks the polymerase enzyme machinery and starts replicating the virus. When the numbers grow about the 2nd or 3rd day onwards, they migrate to other cells and starts the whole process again. And then you get the symptoms of fever, sore throat, cough, loss of smell, and difficulty breathing. In phase 2, it is one of cytokine storm where the body mounts an immune response resulting in massive inflammation, and treatment here is different with oxygen, steroids, vitamin C, and acetylcysteine. I believe that there is much we can do in reducing the severity of the infection at the medical level by treatment in phase 1 early, before the virus replication reaches a critical mass by ivermectin or hydroxychloroquine, zinc and doxycycline. Managing risks. On the issue of exposure and viral load, when we know that the virus is in the community, especially when the new cases are high, cut down on unnecessary travel. Just like this, when you don't take the risk of crossing the road if you don't need to go to the other side. Distancing of 2 meters will reduce the exposure to direct virus, and also speaking at lower decibels will reduce the distance in which the droplets travel. In terms of exposure, wearing a mask will protect the person from the droplets when we talk from spreading into the air around us, as well as protecting us from the droplets from someone who is not wearing a mask. Washing of hands and reduced physical contacts as well also reduce the risk. Closed environment, especially air-conditioned places, will effectively keep the droplets in the air for a much longer period, and thus exposure time is also important. So having a meal outside the restaurant would be preferable. Viral load will also determine whether we can overcome the infection. If the viral load is small, the body may be able to handle it, and those infected will have a mild sore throat. And that's about it. If the viral load is large, then the virus will be able to reproduce, and so you will then have a more severe disease. Those with comorbidities have a higher risk. They have less reserves with their poor immune system. They have higher inflammation in the body. They still should live healthily, sleep well, and take vitamin C, vitamin supplements like what I will cover later on. I believe there is much we can do in reducing the severity of the infection by keeping our immune system healthy through nutrition, reduction of stress, vitamin supplements, exercises, adequate sleep, and reduction of inflammation. On nutrition, we should eat well, taking nutrients-dense food as opposed to processed food. Eat more vegetables, high in flavonoids, a normal amount of protein, omega-3 fish oil, the vitamin supplements like D3, zinc, and vitamin C. Reduce inflammation by reducing the intake of omega-6 oils. Reduce carb as it causes insulin spikes. In terms of exercise, brisk walking on a daily basis for 15 minutes upregulates the antioxidant genes in the body. It will also reduce stress. We can also reduce stress by meditating, practicing mindfulness, and also deep breathing exercises that are slower than 6 breaths per minute. Doing this will increase heart rate variability. You will have a more durable heart and more reserves in both cardiovascular system as well as inflammation. On sleep, sleep well for your age. Quality of sleep matters. It's not just the quantity. It is important to know how much REM sleep you have, the deep sleep you have, and the light sleep you have. Invest in one of those wearables, Fitbit or Garmin, and Garmin VivoSmart, that does the breakdown for you. Healing and building up from the breakdown that occurs with our wear and tear, with normalization of our hormone levels. When we are stressed, our hormonal profiles are skewed towards higher cortisol, adrenaline, and noradrenaline in a fight or flight situation, and chronic stress causes severe imbalances in our hormone systems. The hormonal levels are then skewed towards the breakdown of the body to escape the life-threatening situation, resulting in higher glucose and fatty acids in our body that is not utilized as we are not using it up. One of the biggest area of inflammation is the gut, where our cell lining is only one cell thick, and we have a lot of macrophages and immune cells lining up to prevent foreign proteins and bacteria and viruses from invading the body. If it is extremely leaky, then the inflammation there will be a distraction from the actual infection of COVID-19, and thus the body will not be able to mount a good response to the infection itself, and allows the virus to replicate and reach phase 2 of the infection. You will need, however, to feed your gut with prebiotics so that the trillions of bacteria that live in there will be fed, and thus you will need fiber, both soluble and insoluble. If you should be so unfortunate to get COVID-19, then you will need to double the dose of your vitamin D3, go on to vitamin C, 1,000 milligrams 3 times per day, take quercetin and zinc, drink plenty of water, try not to take Panadol or aspirin to reduce the fever, for you are negating the body's work of fighting the virus by moving the set point to a higher level to combat the virus. Invest in a pulse oximeter that will check your oxygen level in the blood. If the level is lower than 92%, you should consider going to the hospital for monitoring and perhaps oxygen treatment. If you have a doctor prepared to start you on hydroxychloroquine, ivermectin, I would do that. Basically, quercetin and hydroxychloroquine works as an ionophore that allows the zinc to enter the cell. A zinc is charged, so zinc alone will not work. And zinc acts by inhibiting the polymerase enzyme from working. So here you actually are basically stopping the production of the virus in the body. Thank you so much.
Hello, thank you very much for giving me this opportunity to speak. From the perspective of cancer patients do present with a higher risk of contracting COVID, and as a group, when they contract COVID, may have a more severe clinical picture. So this concerns patients who actively have cancer and are undergoing treatment, but also those in the category of having had a solid tumor within the last 5 years. The data we have from the various studies tend to focus more on the hematological and lung cancer patient population, where you may expect that they are more immunosuppressed, particularly transplant patients, and for lung cancer patients may have weakened lungs. The evidence regarding the use of the COVID vaccine in cancer patients is unfortunately limited. We don't have much data in this group of patients. From the American Society of Clinical Oncology, they do recommend that immunocompromised individuals may still receive the COVID-19 vaccination if they have no contraindications to vaccination. Of course, they must be counseled that the production of antibodies in an immunocompromised state may be impaired, as well as the required immune responses to the vaccine. There are particular situations, for example, B-cell depletion therapy within the last 6 months may reduce the protection that the patient develops, and these include anti-CD20, CD10, monoclonal antibodies, for example. In general, the timing of vaccination should be performed before treatment starts, particularly systemic treatment, which means chemotherapy, immunotherapy, targeted therapy. However, if the patient has already started systemic therapy, it is reasonable to choose a particular time in between treatments that they may be free from the drug in order to vaccinate. In terms of patients receiving stem cell transplant, again, this is a fairly complicated issue that needs to be discussed with a hematologist. The American Society of Hematology, as represented by the president, Stephanie Lee, had performed an interview with Dr. Anthony Fauci, who in general recommends cancer patients to receive COVID-19. So just speaking from my particular point of view as an observer of the science involved with vaccination, I just want to bring up some particular points, and perhaps we can use this for discussion. I'm particularly interested to hear our consultant infectious diseases opinion on these points. So a very legitimate question is to ask whether this vaccine, whether it's safe or even effective. Does it truly prevent an infection with COVID, or just reduces the severity of the COVID infection when the patient, despite the vaccination, develops COVID? I think this, to be fair, this question is unanswered in the clinical trials that have been done, because the trial design does not test and follow up everyone who had the vaccine. So we do not know in reality how many patients who had the vaccine were prevented from having COVID. The trials seem to focus on symptomatic individuals and testing these patients. So we know that there seemed to be less symptomatic COVID in those who received the vaccination, but it did not prevent them from getting COVID. So the other concern is pathogenic priming, perhaps typified or exemplified by the example of dengue vaccination, which children in the Philippines, which was highlighted by children in the Philippines who developed severe reactions to the vaccine. For dengue, the first infection is rarely fatal, but if you're infected a second time, particularly with a different virus, this can lead to a much more serious disease due to a phenomenon called antibody-dependent enhancement, or ADE. So when the dengue vaccine was developed, a retired dengue expert from Maryland, Bethesda, Dr. Scott Halstead, argued that the dengue vaccine could have the same effect and warned against this. However, WHO vaccine panel concluded it was safe and it was then given, which led to deaths, very severe reactions, and finally this vaccine was removed. We also know that any vaccine may have acute reactions, for example, anaphylaxis or even death. And certainly there's been some reports in the literature, as you can see here, from the United States, Norway, Switzerland, of deaths very near, in terms of temporally associated with the vaccine delivery. And we also have reports that the nanoparticles in the Pfizer COVID-19 vaccine may trigger rare allergic reactions. And there have been warnings surrounding the Pfizer-BioNTech vaccination that people who have a history of severe allergic reactions should not receive this vaccine. Perhaps another thing to consider, but may or may not be related to the COVID vaccine, but certainly the criticism has been leveled against this vaccine, is that we know from various studies that have been reported in the past, the tetanus vaccine in some cases had been laced with HCG. HCG is the human chorionic gonadotrophin hormone, and this leads to infertility. And this has been detected in many countries, including Philippines, Nicaragua, Mexico, Kenya. And it's curious to me that Pfizer and Moderna have been indemnified against any COVID vaccine, severe COVID vaccine side effects. This to me is interesting. We fully understand the hype surrounding the pandemic, that everyone needs to be vaccinated as soon as possible. However, if you step back and think about it, this seems to be a very unusual development. So I think in summary, I would say the COVID vaccine can be considered by patients, including cancer patients, but I think it's very fair to say that we do not know a lot about this vaccine. There's a lot that's unknown about this vaccine. Certainly there are, to call it effective cure against COVID, I think may be premature. But we know that these vaccines are experimental. Given we do have some evidence in the literature, but I would say that this evidence is fairly preliminary at this stage. Of course, our esteemed expert may disagree with this point of view. So I just want to highlight some resources if any of you would like to do further reading. Thank you.
Okay. Hello. Thank you very much for inviting me to give this talk at your conference. I've been asked to speak about the status of the currently approved COVID-19 vaccines. But before I do that, I should probably go and clarify some terms that I'll be using during the talk so that we're all on the same page. Oh, so I have to do it this way, sorry. So as we all know, COVID-19 was first detected actually in December 2020 as multiple cases of hospitalized pneumonia in Hubei in China. After some delay, this was quickly identified as a previously unknown coronavirus. Coronaviruses, by the way, are common viruses that cause flu-like illnesses in the wintertime. So this was not unexpected, except that it was a strain that had not been previously identified. And then subsequently, there was a super spreader event in the city that had a very high number of cases that then took this disease to other parts of China and then worldwide. By January 10th, 2020, the genome was mapped for SARS-CoV-2 or COVID-19, as this virus is now known. And by March 2020, the first mRNA, which stands for messenger RNA vaccines, went into clinical trials. Just to understand why there was such a rapid transmission of this disease and why it's causing this terrible pandemic that we're in, there is a huge degree of both symptomatic and asymptomatic transmission. So this has taken place on airplanes. There have been huge cruise ship outbreaks, and there have been many super spreader events worldwide. The first outbreak in Boston, actually, the city in which I work, was related to a huge technology meeting in March of 2020, where there were 20,000 international attendees who then took the disease back to wherever they came from. So this is a cartoon of the SARS-CoV-2 virus. I don't know if you can see my pointer, but the blue things that are projecting out from the viral envelope is the spike protein. The spike protein is the thing that attaches the virus to receptors on human cells. This gray wavy thing inside is the RNA, which is the genetic material for this particular virus, which is an RNA virus, meaning it has RNA in its genome. Viruses are usually made from either DNA or RNA. And this is a single-stranded RNA virus with an envelope, which is this pink wall that you see here. These little yellow things are the envelope protein, and then these smaller ones are what's called the membrane protein, which are the least frequent ones described. So just so that we can understand what we're all talking about, I'm going to show you a brief comparison of COVID and influenza. With COVID-19, pneumonia is extremely common, whereas not so common in influenza. Much higher mortality, 3 to 4% overall, if you count younger people through to the elderly. But in the elderly, the mortality rates can be over 80%. The R factor, which is referring to the number of people whom one person who is infected will infect. So the higher the number is, the worse off we are in terms of transmission. So the R factor for COVID-19 is 6 to 8. Meaning one infected person can infect average 6 to 8 different people. With the new variants that have been described in the UK, for example, where they think there may be more infectious, the R factor may be higher. Influenza has a much lower R factor, and depending on the strain of influenza, it's only 1 to 3. And then, as I've referred to before, there is a very high rate of pre-symptomatic and asymptomatic transmission. COVID-19 is actually most infectious at the very beginning of the disease. So you're actually most infectious 2 or 3 days before you actually come down with symptoms. And then for about a couple of days, there's still a high viral load in your body at the onset of symptoms. So because you have such a high viral load, that makes the R factor very high. And since you don't have any symptoms at that time, you're not doing anything to avoid transmitting it to someone else. And of course, there is a significant population, about 25%, that never have any symptoms, but they can certainly be infectious to someone else as well. So as we stand here in January of 2021, there have been record daily case numbers in the US and worldwide that are really causing a lot of alarm in health services all over the world. We have more than 300,000 cases per day on some days in the US. In Spain, which is another hotspot for coronavirus, the daily case numbers have increased to more than 25,000 in a smaller country with much fewer people in the population. So this is a graph of what has happened in the US. The very first small peak is what happened in March. The first case in the US was actually detected on January 20th when a Chinese man returned from Wuhan and came back to Washington State, where he then lived after he visited his relatives. So he got on a plane when he was very symptomatic, when he was asymptomatic but very infectious. And came and developed symptoms within a day or two after he came back. The second wave was sometime in the summer when we had let our guard down. People were no longer so careful about social distancing or masking. And there's this second peak, and then this huge peak that we are facing at this point in time, in terms of cases by day. This is just to show you again how bad it is in the US at the moment. Nowhere is there less than 25 per 100,000 population in any of the states, including Alaska. So we're not doing very well, I'm afraid. I understand from Dr. Yao that the first Malaysian to be diagnosed with COVID was on February 4th after he returned from Singapore with a fever and a cough. But prior to that, there were 8 Chinese nationals who were also quarantined in Johor Bahru on January 24th after coming into contact with an infected person in Singapore. This is a slide that was very kindly given to me by Ms. Lim, and it shows, I don't really know how many cases are actually being checked in Malaysia and what is the availability of testing in Malaysia. My understanding is that kits might be limited and that it might be somewhat difficult to get tested. Excuse me. I also understand that the cases are primarily being taken care of in government hospitals. So to what extent people are not coming forward to be tested, I don't know. Certainly it is not that easy despite the widespread number of tests that we have available to be tested in the US either. So this is the global picture, just to give you an idea. The US is obviously one of the worst. And here's the UK, Spain, with the darkest, with the highest, incidence per million population. South America is obviously very much affected. Africa has been spared to date, and that's another story altogether, in terms of the transmission of COVID-19. But recently, because of a decrease in terms of the precautions that they were taking, the rates have really been spiking as well. So this is just a number of useful websites which are free to everybody and accessible to anyone. When we first had to take care of so many COVID patients in the hospitals in the US, everyone was afraid. We didn't know anything about the virus. We didn't know how to treat it. We didn't know, how it was really transmitted, et cetera, et cetera. Fortunately for the internet, there were weekly or bi-weekly or sometimes daily webinars and seminars, both at the level of our own hospital or the medical society at the state level, and certainly at the professional society level, like this third one stands for Infectious Disease Society of America. And they are still continuing to have weekly or bi-weekly webinars as things went along. So let me turn to the subject of vaccines and why the two currently approved vaccines are mRNA vaccines. As part of the operation to deal with the pandemic in the US, something called Operation Warp Speed was formulated. It was a partnership, very unique partnership actually, among components of the Department of Health and Human Services, including the CDC, the National Institutes of Health, and the Department of Defense, as well as private firms. And that included pharmaceutical companies, companies that made syringes, needles, all the things that have to go into preparing vaccines for public consumption. So by taking away the financial risk of investing in the research, as well as taking away the financial risk of having vaccines that would not be distributed to the public, the government was able, with public money, to really facilitate the development of these vaccines. And at the same time that these vaccines went into clinical trials, they were rapidly revving up the system to manufacture these vaccines as soon as they were approved. So, for example, the Pfizer vaccine was approved, I think, on the 11th of December, and by the 14th, it was being injected into patients' arms, something which would never occur in the process of the normal approval of vaccines. However, despite what some patients' concerns, the approval was not flawed in any way. It was still evaluated by several independent groups of people who normally approve vaccines outside of the federal government, and therefore, came fully validated by the scientific community. So why messenger RNA vaccines? There are several benefits to that. First of all, it is a very small element. It is non-infectious. The mRNA that is in these vaccines were made in a laboratory. They were not derived from the virus. Has a very short manufacturing time, and also in the future, the potential for targeting multiple diseases. So what that meant was the process could be standardized and scaled up very quickly, making the vaccine development very rapid. And then it was moved very rapidly into the clinic for public consumption. And we've actually had the technology to make messenger RNA vaccines for a long time, ever since the 1980s, actually. So the technology is not new, except that the early stage clinical trials to try to develop vaccines using mRNA for influenza, Zika, and rabies did not pan out. So it was never mass produced. So the two mRNA vaccines that have been approved are very similar. They are both mRNA held in a lipophilic nanoparticle, meaning lipophilic means fat-loving, and which is true for a lot of vaccines. They have to be kind of wrapped in a lipophilic, well, something that loves fat in order to be injected into the body and taken up by the cells. So both consist of 2 doses. The second dose I given either on the 3rd week or the 4th week. The Pfizer vaccine is approved for people 16 and over. The Moderna vaccine is approved only for people 18 and over. Both are equally efficacious, but the studies were to study the effectiveness for people with symptoms, and also they divided up a subgroup and studied whether this was effective for people with severe disease. And by severe disease, they included anyone who was sick enough to be admitted to the hospital. Most of the patients that we see who come in through the emergency room with COVID don't have to be admitted. But unfortunately, what we've realized is that the second week of illness, they can crash very rapidly and become very short of breath. So they're actually sent home with an oximeter, to look at on a regular basis and to call us or come back into the emergency room should they feel worse or if their oxygen level goes down. We have more information about the Pfizer vaccine just because it's been around for longer. And we all have heard of the lady in the UK who got vaccinated and had anaphylaxis that had to be treated. So subsequent to that and another 2 cases that were described in the UK where Pfizer vaccine was approved before it was approved in the US, there was a great deal of caution taken about monitoring people for anaphylaxis. Or I should say that anaphylaxis is referring to an immediate life-threatening reaction to either a drug or a vaccine. And this usually consists of somebody who's short of breath. They may feel like their throat is closing up. They may become hypotensive, maybe that is, they may drop their blood pressure and they may pass out. These patients usually do not have a rash, so that would not be the first manifestation of anaphylaxis. So these 2 studies did not by itself study asymptomatic infection. However, there is some data from the Moderna trials where they can actually measure asymptomatic infection, and that data is still pending. So as of December 23rd, about 2 million doses of the Pfizer vaccine have been administered in the US, and about 0.2% of adverse events have been submitted to the vaccine adverse event reporting system, which is one of the ways that we report to a central system about side effects from drugs or vaccines. The mRNA vaccines have another way of being reported to the CDC. After you receive your vaccine, you are invited to download an app onto your telephone. And what that enables the CDC to do is send you a text every day for 14 days to find out whether you've had any side effects. So they hope by doing that to collect a lot of data, because the initial people who have been vaccinated to date have been healthcare personnel. So hopefully they will be more interested in helping collect that data as well. So as I said, they have studied all these people, who have had anaphylaxis with the Pfizer vaccine. They determined there were 21 cases that was really anaphylaxis. So that's about 11.1 per million doses. If you compare that to flu vaccine, which is 1.3 doses, 1.3 cases of anaphylaxis per million doses. So 86% of the people with anaphylaxis had symptoms within 30 minutes of vaccination. And most of them had a history of severe allergies, including some with previous anaphylactic events. 90% of these events occurred in women, but then in this particular population that they were studying, 64% of the vaccinees were women. So that's hard to make a conclusion out of that. All have recovered, and of the remaining case reports that were determined not to be anaphylaxis, 86 were judged to be non-anaphylaxis allergic reactions, meaning people thought that it was a real immunologically derived reaction to the drug, as opposed to a non-allergic adverse event, which would include things like diarrhea, headache, fatigue. Those would be considered non-allergic adverse events. So because the vaccine is being rolled out in hospitals, in long-term care facilities, as well as being rolled out through CVS, which is one of the big drugstore chains in this country, and I think Walgreens as well. They have set certain criteria for these vaccine locations. You have to screen for whether someone has any contraindications or precautions. You have to be able to have the supplies and treat somebody should they have any kind of anaphylaxis signs and symptoms. And you also, all the vaccinees are asked to wait for 15 minutes in an area where they can be observed. And if they are felt to be high risk for some kind of reaction, they are observed for 60 minutes. I just want to comment. So anyway, the only real contraindications at this point to messenger RNA vaccines, which is defined as, by the way, any immediate allergic reaction occurring within 4 hours. They decided to set the bar very high. So it is contraindicated to vaccinate someone if they've had anaphylaxis or an immediate reaction after a previous dose of the mRNA vaccine or any of its components, and that includes polyethylene glycol or the related polysorbate. And those two things are, the lipophilic nanoparticle that I had told you about. However, if you have an allergist think that this is probably the risk benefit is better for you to get the vaccine, the vaccination can be considered in a controlled setting. There's actually a clinical trial that's going to be started at the National Institutes of Health to try to vaccinate these people under a very controlled setting. If you have a precaution to vaccination, that would be considered if you've had a problem, an allergic response to any vaccine or injectable therapy that is not related to the mRNA vaccine or polysorbate. So all these other, history of allergies to venom, insects, egg, gelatin, other oral medications are not considered contraindications. At the moment, the current thinking is that people are probably reacting to the polyethylene glycol or the polysorbate, but this has not been established. So just a word about PEG or polyethylene glycol. It's a common laxative, but it's also used in many vaccines. So for a country like Malaysia, where I don't know if people still do tuberculin testing, but the PEG is a very close relative of tween, which is found in older formulations of tuberculin test reagents. So if someone has had a severe anaphylactic reaction to a laxative or to tweeting, they should really use precaution about the mRNA vaccines. So there's actually a website where you can find out all the different things that are related to. The other concern from a public health viewpoint in the US was public acceptance of the vaccine, because they've been doing serial studies about who, if offered a COVID vaccine, would actually accept the vaccine and want to go ahead and get that. And there is a lot of concern about this being an RNA vaccine, which most people think of as part of genetic material, of a cell. There's really no risk of the mRNA modifying the vaccine recipient's genetic makeup. This could theoretically happen with the DNA vaccine, but the mRNA vaccines introduce a sequence into the cytoplasm, which is not the nucleus where the genetic material is, and instructs the cell to synthesize the spike protein. The spike protein is then excreted locally from the cell or presented on its cell surface to stimulate an immune response. So the mRNA actually just uses the cell to produce protein and then degrades after just a few days because it's very unstable. No effect on host DNA is possible because, as I mentioned, this all occurs in the cytoplasm of the cell. And they've actually added a comment about this to the mRNA vaccines so that to allay some of the public concern. Unfortunately, the hope was of our outgoing president that 20 million doses of vaccine would be given out by the end of 2020, but it's been off to a very slow and messy start. There's several factors, responsible for that. One, the vaccine is difficult to transport, especially the Pfizer vaccine. It requires sub-zero deep freeze conditions. So the planes have to be, it has to be transported in liquid nitrogen or dry ice. The Pfizer vaccine actually comes with some normal saline as well as the mRNA, and you have to put it together in order for the vaccine to be injected into someone's arm. The Moderna vaccine is easier to ship and store because it can be stored at the regular freezer temperature, and it will remain stable for a little while afterwards. So that was one factor. The other factor was that people were concerned about getting the vaccine because of the allergic responses that have been described. And then, of course, there were political reasons for people thinking that the vaccine, since it took such a short time to formulate and get into the market, there must have been something not too savory going on. But that's really not the case. So the US and the UK have taken two different approaches to this mass vaccination campaign. Initially in the US, on December 14th, when the first patients got the Pfizer vaccine, the aim was to fully vaccinate with 2 doses of vaccine within either 3 or 4 weeks based on the clinical trials. So if a patient came in and got the first dose of the Pfizer vaccine, another dose would be held for them so that they would be able to get the second dose at the appropriate time. Who was prioritized in terms of getting the COVID vaccines? there were multiple committee meetings among all the professional societies, and the aim was to protect the people with the highest risk of mortality, and also to protect the people, who were most seriously affected by COVID, as well as had the most likelihood of being exposed to COVID, and to keep the society going. So whereas 80% of the deaths occurred in people older than 65, only 65% of cases in the US have occurred in people younger than 50. So you can see that it's not good to get COVID if you're over 65. So given that, by the way, the federal government would distribute the vaccine to each state. There were some guidelines that were set forth, but there was no requirement that the state had to follow, because it was basically left up to the state to determine who they were going to give it to. So the ACIP recommendations were the 1A people are the healthcare patient-facing personnel, so anyone who worked in the hospital and took care of patients, as well as long-term care facility residents, because at the beginning of the pandemic, first of all, these patients, of course, are mostly elderly, and there were huge outbreaks with a very high degree of mortality in these facilities, due to the transmission from patient to patient, and very often from staff to patients as well. Malaysia, fortunately, does not have this problem, at least not yet, because we don't have too many long-term care facilities. And then, as you can read, 1B would be the frontline essential workers and patients over 75, and so on. So these were the lines that were forming in Florida, where if, there's a lot of elderly who retire in Florida because it's warm. So they have decided to prioritize people over 65. So amongst the first group that were available to get the vaccine, you could just call up your local hospital and you could get a time and a day. But of course, there were long lines because of that. So I had mentioned that we were planning initially to give 2 full doses to everybody who got the first dose. But we have a president-elect who is alarmed by what is going on, because the rates are going up, up, and up. So he's decided to release nearly all the available vaccine doses, and he will not be holding back the second doses in an attempt to decrease this flood of cases that we're having. And he has said that he's determined to get second doses for everybody who gets a first dose. So let's hope that the companies can step up and do that. The UK has decided to have another approach to mass vaccination. This is thought to be an experimental approach because they've decided to give a single dose of the AstraZeneca vaccine, which is the one that was formulated by the University of Oxford, or the Pfizer vaccine. I think Moderna also just recently got approved in the UK, rather than holding back supplies for an on-time second dose. This is speculative at best, but I think most people can understand why they are doing this, because their rates are so high. And with the development of the variant that is spreading like wildfire in certain parts of London and the UK, I think they would like to get vaccine into people as quickly as possible. The studies, however, that were done with any of these vaccines, you cannot find any data to support this. And there is, really concern about several things. First of all, we don't know the duration of protection of 2 doses, let alone 1 dose. And there is a lot of concern that if a person has been vaccinated and doesn't get the 2nd dose, basically what will happen is he or she will have very low levels of antibodies. He or she may think that they are protected. And also, that is also a situation where people who deal with infectious diseases are concerned about possible induction of viral resistance in the population, because that sets up an environment where it's very easy to induce the resistance because you're not really protected, but the virus is trying to find some way of getting around the low levels of antibodies. So going to, I had spoken briefly about what we don't know currently about the approved vaccines. We don't know how long it protects us, even if we have 2 doses. The 2 vaccines were approved. The 3 vaccines were all approved based on follow-up data 2 months after the 2nd dose. We don't know about the effect on asymptomatic infection. We don't know the effect on transmission. And it's really unclear at this point the effect of the new variants on vaccine effectiveness. So just very briefly to tell you about the AstraZeneca vaccine. It has been approved in the UK, of course, and several other countries. It's also formulated to develop immunity against the protein, but it is being carried by an adenovirus, which is a common cold virus. But this virus has been made non-replicating, so it actually doesn't divide in your body. It's inexpensive to produce and will be sold at cost and shipped and stored at normal refrigerator temperature. So that's definitely a plus. It's been found to be 100% effective against severe disease, like the 2 mRNA vaccines, but much less effective against all symptomatic disease. So on an individual basis, you're certainly better off, it'd be based on good data. If you got the mRNA vaccines, that would be preferable. But this vaccine is cheap enough and also much easier to transport to reach hard to reach areas in the world. So they're rapidly building up their capacity, for 3 billion doses of the vaccine. So I'm going to end very quickly just to tell you how many people as of December or January have been vaccinated. And you can see that, 1.79% in the US, that is really a fraction of what is needed. With the new variants, it is estimated that you need at least 70 to 90% maybe of the population to be vaccinated to get herd immunity. So we are a long ways off from that. I haven't talked about the various other vaccines, like the Chinese have several vaccines. Some of them were being vaccinated in their own people, despite the fact that the clinical trials have not finished. Well, they just finished recently, I believe. But nothing has been reported in the international literature about the risks and benefits of these. So it's certainly very difficult to evaluate. As far as we know, the one that is most commonly used has about 78% effectiveness, but we don't know anything about the side effects. Well, thank you. I'm going to end here. So stop sharing.
Thanks, Rini. That was a great talk.
Hehehehe